And
Hey.
I have you on virtual camera here, so we are live. And I'm choosing a case to review. And I like to review a non-spine case. So,
Okay.
and this case 10 seems to be a good case to review. And let's start. And I'm not sure, is anybody with us at this point?
Are you
Anybody?
live on YouTube?
I think I am. Can you check if I am? Because my I broadcasting it already live on YouTube. Please make sure that everybody is there.
Yep, I see it.
Okay. Now, um, so this is an actual case that I had about 3 months after I started I was done with the residency, and I start my position as a neurosurgeon in Sioux Falls, South Dakota. It is a sad case, but as well, it has some shiver of light in that in the whole thing. So, I'm practically this is my third month starting after my residency, and I get called to the ER for a young boy, 7 years old, that suddenly turned unconscious. Literally, that just had the time to tell to the parent that that he has a very very bad headache, and then literally turned unconscious. And the parent, the, the drove the boy to the ER by themselves. The mother was as well a doctor in the same hospital, and the practically I was called there to evaluate this young boy. And obviously, in a situation like that, they get a CAT scan, and in the CAT scan, they are seeing this, and they called me to come and evaluate this patient. Now, I'm not sure if anybody is there that can maybe like a dialogue help me to literally to maybe answer some question and talk together about what this case entails. Amanda, yeah, I know this is not something you do, and that's nothing. You're not in medical fields and so on. But um, I'm sure you can empathize with parent, their boy that was doing well, no problem, all of a sudden is not responsive, practically comatose. They cannot wake him up, and so on. So it was a very emotionally loaded situation for them, and because she was a doctor in the same hospital, for everybody else. So, what do you think, Amanda? What are the situations that a person can become unconscious, just as a layperson? What do you think? What is the
Lack of
consciousness?
oxygen would make someone become unconscious.
Definitely, definitely. And that is something you can easily identify in a ER by putting what you call blood oximeter, meaning you put something on the finger, you see what the saturation of the blood is. And the vitals at that point for this boy was okay, meaning that oxygenation of the blood was okay. So that was not a problem. But because this patient was unresponsive, he got intubated because later on start actually breathing irregularly in the ER. So what else do you think? What is consciousness, and why a person can become unconscious?
Consciousness is, I would say, reacting to stimulus.
Yes. Yeah, and being able to communicate with the outside world. And so, and it's a function of the brain. So practically every kind of being a problem with the consciousness is a problem of the brain. And so lack of oxygen is one, and any kind of trauma to the head is one that just sort of bring our brain out of balance. And more importantly, if there is a pressure inside of the brain, that pressure can be because the brain has fluid inside that we call that cerebrospinal fluid, or CSF, cannot circulate. In this case, we are looking at the CT of the head, and there is a white, what we call hyperdensity inside of the what we call cerebellum. For people who are familiar with that, our brain is compartmentalized, meaning that if I bring an anatomy of the brain here, this is our brain, and obviously this we call cerebrum. On the bottom of the brain, there is a part that manage our motions and reflexes and things that we don't really pay attention consciously, that we just walk. We don't pay attention how we walk. That is managed by cerebellum. And obviously there is a tough membrane around the brain everywhere, and there is a tough membrane actually between cerebrum, big part of the brain, and small part of the brain. We call that part tentorium. And if you look at this anatomy of this patient now, we see here the tentorium here and here, and in bottom part of the brain there is this very large bleeding, and that sort of causes pressure on the brain, obviously, and on the brain stem, which is extremely crucial for us, and prevents literally as well the fluid inside of the brain to circulate, the cerebrospinal fluid. There is a structure here we call the fourth ventricle here, right here. If this any kind of mass push on it, prevent the circulation of the fluid inside of the brain, and that creates a situation that we call hydrocephalus. And the way we know there's hydrocephalus, obviously, as you see, I have put some arrows here, that here, what we call the temporal horn of the lateral ventricle are very well visible. Usually that structure should not be visible in a regular person. You can see lateral ventricle, but not the temporal horn of the lateral ventricle. And you see how big it is because the pressure is backing up. Now, one of the problems with the fluid inside of the brain backing up is that the pressure, it's a confined within our skull. There's a limited amount of space. If that space is backing up and it's more fluid there, it increases the pressure. And once the pressure goes above certain point, the perfusion of the brain become more difficult, because blood pressure trying to push the blood in for oxygenation of the brain, but the pressure inside prevent that. So practically, hydrocephalus is one of the emergency situations that can cause people lose consciousness. But as well, in this case, the pressure itself is pushing on the brain stem. The bleeding is pushing on the brain stem, and that as well is an area that is very important for our consciousness, in an area that we call periaqueductal gray, or the reticular formation around the spine. That is the area that practically is a pacemaker for our consciousness. If that area under attack, we lose consciousness. So, and obviously, this is a very crucial, very vital structure in our body, that it's extremely important that we...
Oh, Dr. Coach is in the waiting room, I think.
Okay, I'm adding Dr. Coach. So here's Dr.
Sorry, I haven't been keeping up with the comments on YouTube. Do you want me to tell you as they're coming?
Yeah, tell me if somebody has a question, I can answer that. So, as we discussed, this is a 7-year-old boy who all of a sudden became unresponsive, practically went in coma, carried by parent to the ER, and the patient is already intubated, and I'm in the ER, and this is CT, and I'm going to start with the exam. What was my exam of this patient? Now, Is there any question that that I should answer, Amanda?
No, people are just answering your questions.
Okay. So, Dr. Coach, I am in the ER with this patient, 7 years old, unconscious. This is the CT. I'm going to examine the patient. Ask me what exams I should do, and I give you the result of those exams.
Okay. So you already had the CT done.
Yeah, this is
You're saying.
CT. Are you able to see
Oh,
the
I can't.
CT?
I can't see it. No, I can't see
Okay,
it.
let me share the CT here. Okay, this is the CT of the patient. But I'm in the ER. Obviously, the first basic part of any the interaction is the exam. What
Sure.
exam should I do for this patient?
Well, the first thing you want to definitely do is inspect and kind of see, overall what's happening with the patient. Are the eyes open or the eyes closed? Is he
Well,
uh,
patient is intubated,
intubated? You said
not
okay, right? So
sedated,
right,
but the
okay,
eyes are closed. Now,
yeah,
GCS is in the
yep,
basic part of the exam.
sure.
Obviously, for the children, toddler that don't speak, there's a different scoring system. But for anybody can speak, GCS is a very good way of. And GCS for this patient is actually 4 or 5. What does that mean?
That's pretty severe. So
Yeah. What
if
does
it's
that
lower,
mean?
less than 8, well, it means he's got a serious traumatic brain injury. He's basically in a coma. Um, if it's less than 8, then that's considered severe. So yeah, it means that something bad is going on, basically.
Yeah, here, this is the GCS
Sorry,
score.
just for us laymen, what does GCS stand for?
Stand for Glasgow Coma Scale. Here, I have it here. This is a standardized test that whenever somebody is irresponsive and you think that it's a brain injury or practically anybody who's unconscious, you have to get a Glasgow Coma Scale. It's come from Glasgow, practically Scotland. It was standardized there. That's why it's called Glasgow Coma Scale or GCS. Practically, first of the thing, you interact with the patient, you see if their eyes are open. They get certain point depending on how the eye reaction is. Then verbal response. You remember I said for the children that don't speak, there's a different score because you need to have a verbal communication with the patient, and then you get motor response. So in this patient, the eyes were not closed. There was no verbal response, and patient was actually extending to stimuli. So 1 point, so Glasgow Coma Scale goes from 3 to 15. In this patient, it was 1 and 1 and 2. And extensor, practically what it means that the patient extending the arms and the legs. Now, this is extremely important because imagine our brain has developed over millions of years in a certain path, meaning that certain areas of the brain are older than other area of the brain. Now, imagine how does a fish swims? It coordinates the muscle, make itself really straight and then move back and forth the tail. That area of the brain is well described actually. And that area of the brain requires very, very little oxygen. It's a very robust area. Meaning that that is the last area of the brain to go out. Meaning that when we have very little oxygen or we have a huge damage, the only area of the brain that's still working is the area that keeps us literally, these people are extending the arms and the legs, they are rigid, like you barely can move them. They are, have you seen anybody like that, Dr. Coach?
Yes.
Okay, so now imagine the damage is not too bad that they are extending. Then other area of the brain are still active. So it's very easy. Once the fish came out of the water, they had to work against the gravity. So do you see the flexion? They say that flexion is better than extension because that area of the brain is, we call it flexion, but it is practically anti-gravity, meaning that the legs are still extending, legs are not flexing, but the arms are flexing. What does that mean? That what do we need to be able to be upright against the gravity, like a mammal or even reptile? Okay, we have to extend our leg and use other muscle against the gravity. For that reason, as you see in the extensor rigid spines decerebrate and abnormal spastic flexion decorticate, meaning here practically entire brain is out of function, just the brain stem is working. Here the cortical part of the brain are not working, but the midbrain is still functional, so you get more point for that. After that, you have to see what is the response to the pain. Are they withdrawing from the pain, or are, like, imagine if somebody you have to cause them pain, unfortunately, for this exam. If you push on something with the, that is what I do. I use a pen, put it on the nail, and I push hard. Here is not the time to be
sensitive.
Okay, as a matter of fact, I had to throw, now a patient is dying. I had to make a diagnosis and react on that. And then unfortunately I had that some younger nurse that don't understand what the situation is and thinking, oh, he's so mean, causing patient pain, and so on. In that situation, you have to get out of the way and let the professional do their job.
Yeah,
so
that's exactly right. No?
So a pen on the nail, you push hard. What does the patient does to when you do that? If they just withdraw to the pain, you get 4 points. But if the patient with the other hand comes and try to get rid of that stimuli, like you're causing pain here, with the other hand tries to push you away, get purposeful movement to painful stimuli. Okay, so you get different kind of, and obviously if they obey command, they get the full score there. Now let's go back here. This patient is.
Sorry, Dr. Abbasi, can I interject one thing before we get back to the patient? I just wanted to quickly clarify for everybody that, so the Glasgow Coma score, the worst score is the lowest score, the best score is the highest score. So if you have a 15, that means that you're basically fine. If you have a 3, it means you're in a very, very severe coma.
Yeah.
So the lower the score, the worse. I just wanted to point that out.
Yeah,
I'm sorry, go
absolutely. Now, this patient's GCS is 4. This patient is not in a good shape. This is one of the lowest scores you can get. That means the brain stem is still working, but everything above it is not working. Now, what other exam is there to do here, Dr. Coach?
Well, I mean, one thing you might consider also is there any other injury besides the brain injury? I don't know. I don't know what the findings were when the patient was found, but
no, it's on the skin. There's nothing on the skin.
Okay.
So no trauma. There's no sign of trauma.
Mustafa's in the comments. He says pupil size reflex. He said that a while ago.
Perfect. That is the basic thing. After GCS, the pupil. There are 2 things we check on the pupil: pupil size. Actually 3 things: size, if they are asymmetric, and the pupil reaction. And the reaction, we check the direct and indirect reaction. That is why you see every neurologist or neurosurgeon with the light.
Yep.
You won't walk in the hospital as a neurosurgeon without the light. So what do we do?
You have to put the light into one eye, and then you watch what happens to that eye. You see if the pupil responds, but at the same time, you have to also watch the other pupil and see if that's responding as well. That would be the indirect portion.
So first thing we do, obviously, before even that, we open the eyes, we look at the size of the pupil.
Right, true.
A patient in coma has small pupil. But when the brainstem starts dying, the pupil get bigger. Now, that is one of the things we do. If you open the eyes, the pupils are big. Unfortunately, there is not much we can do, except patient is on a medication that make the pupil bigger. If the patient is on no medication and the pupil are big, really big, that is a very bad sign. Now, if the pupil are small, that means that there's still some function is there. Now, even small pupil or smaller pupil, if you put light in it, it gets smaller. We call that pupil reaction. You can try it on anybody, can try on yourself. Go in front of the mirror, look at the light, and then look at your pupil size. It gets smaller. But it is very important to understand that even if you put the light only on one eye, both eyes get smaller. Both pupils get smaller. And that is what we do. We call it swinging eye test. Put a light in one eye, but we are looking at both eyes, that when we go from one eye, they get both smaller. In the time we are trying to go to the other eye and take the light off, the pupil get bigger, but when we get to the other one, both get smaller again. This is beyond this conversation, but based on how they react, if one pupil make the other one smaller and bigger, or not the other way, and so on, we know at what stage or what location the damage can be. So this is important. Now, we talked about the pupil response, and we talked about the GCS, and there are some other tests that in this situation we can do, but that is practically for the emergency situation, more or less, with this picture, that CT that's available, it's all you need to know. Patient has severe bleeding in the cerebellum and has hydrocephalus and practically is deeply comatose. So what is the next step? What do we do?
So in the comments, Mustafa's commenting, but they're a little bit delayed. So he says direct consensual reflex.
That is the direct and consensual, that when you put the light in one pupil, the other one gets smaller. That's a direct, the same eye. Consensual is the other eye.
And he also says APD.
APD, what's APD?
Mustafa, you're going to have to tell us what APD is. There's a delay, so it might take a while.
Okay, so just tell us. So, but what is the next step? I mean, 7-year-old, everybody, when a young child get in the coma and everybody's excited and they call me, what is the next step?
Maybe measure the ICP.
Well, this patient is about to die.
True.
So what am I going to do? Decrease the pressure. There's no question that the ICP is high in this patient.
Okay, so burr hole to
Look at the temporal horn.
Yeah. You can see this now.
That the patient has hydrocephalus. Right. Now, first of all, let's talk about the differential diagnosis of this patient. Okay, what's the differential diagnosis of this finding? There's a bleeding inside of the cerebellum in a 7-year-old boy. Any takers? Well,
tumor, astrocytoma.
Trauma, tumor, vascular abnormalities. These are the three main things. Okay. Yep. Now, there is no history of trauma, and even if the parents say it's no trauma, we check for trauma and so on. There are signs of trauma. We always check that. Vascular malformation versus tumor. Look at that. There is huge edema around. Edema is when the tissue swells up and that darker spot halo around the tumor, around this mass, around this bleeding, that is extremely suspicious for tumor. Now, what is the most common childhood tumor of the brain?
Is it a pilocytic astrocytoma? Or is it?
That is not the highest for the children. That's probably number 3 or 2 or 3 or 4. Okay?
Neuroblastoma?
Medulloblastoma.
Medulloblastoma, okay.
Medulloblastoma is a cerebellar tumor that comes usually from vermis, and vermis is the middle part of the cerebellum. That's the most common kind of thing. Now, I am setting up I already have called the OR. They are setting up the room for emergency, but it's going to take a little bit. What is the best thing I can do? I'm going to go to OR and reduce the pressure, because if I don't, this patient will die. This patient will die in the next hour. if we don't reduce the pressure. But I am on the way to the OR. I think it's a tumor. What is the most important information would be useful to me in the OR about this young boy that can really influence my surgery? And that is where the vessels are, or is this truly a vascular malformation or tumor? Because a tumor has behaved differently in the OR than a vascular malformation. A vascular malformation is like a vessel, like an artery becomes a vein and it has high blood flow. If you're not careful, you touch them and they burst, explode, and you literally bleed out. Okay, that's a very important information. So in that time, they are setting up the OR. I get a so-called CT angiogram, which takes just a few minutes to get, and it tells me, no, this is not a vascular malformation, this is a tumor. And I get a CT. So now let's go back here. I'm in the OR. Now I'm going to show you what the positioning of the patient be. Cerebellar. I'm not going to use the OR pictures because this is open for everybody, but positioning. So I'm going to show you how we position a patient for surgery in a situation like that. Now, not sure, you guys able to see this or not?
Yeah.
So we put this device is called the Mayfield. It has two pins on this side, one pin on the other side. Believe it or not, this is the gentlest way to hold the brain still when you are doing surgery, because obviously you understand brain cannot move, skull cannot move. So two pins from here, one here, one here, and one pin here, and we turn it like clamp the skull in these pins, and then it holds his brain still. And then in this patient, obviously, I shaved all the head here, and then I make an incision like that, as you see here. Then I push.
Is the dotted line is the dotted line an incision?
Yes, it is. And then I open up the skin, push everything to the side, and then visualize the skull. Then I make borehole. There is a device we call craniotomy or perforator. We put it in. It has a part that when it goes through the skull, it stops. So I put two holes here. Then take the skull out, and then right underneath is the dura, and I already see there is huge pressure there. And one of the first things I do to reduce the pressure, I make a small little nick and let some of the fluid come out. Okay? And that is help to reduce the pressure. And then pretty soon after, what I do, I open up the dura. Okay, this is the bone and the and so on, and then I take the bone out, and then here's the dura. I open the dura, and the brain is squeezing itself literally out. So at this point, it becomes, I use it, what we call bipolar and suction. I open up the what we call cerebellar hemisphere, and gently get to where the bleeding is, and I suck most of that bleeding out here, as you see here. And that already reduces the pressure quite significantly. So that is reduces the initial danger of the brain squeezing itself and become practically prevent the blood perfusion of the brain. Now let's look at some of the picture after the surgery. So here you see that this is the area of the skull that I took out. Obviously, brain is damaged, brain is angry. We don't put that piece of skull back anymore. We keep it out, okay? And here that you see that there's a piece of skull is missing here. What you don't see is what's important. You didn't You remember in the first picture, you see all this hyperintensity and the blood. Now you don't see that anymore. Okay?
Mm-hmm.
There's another thing you see here. Do you see that white here? You didn't see it in the last picture. You didn't see it here, but now you see a white something here in the what we call the ventricle. This is a device. This is just a like a pipe, like a hose, very small hose that we put in the where the brain fluid is, CSF is. We call that external ventricular drain, where we put in the brain to literally give the brain fluid CSF an alternative path to come out and not squeeze the brain.
So Mustafa is wondering, does mannitol have a role in these types of injuries before the OR?
Yes, it does. Yes, it does. And you know, mannitol has been traditionally used to breach the time. Yeah, a very good question. And what mannitol does is actually attract the fluid from all our tissue inside of our brain, inside of our bloodstream, to reduce the amount of the fluid that is in the tissue, and so reduce the pressure inside of our brain. So this patient is already has gotten, based on the weight, they get certain amount of mannitol, and it does. Mannitol, Dr. Coach, do you know what mannitol is?
It's an osmotic diuretic, I believe.
It's a sugar.
Yep.
It's a sugar that our body cannot process, and it stays, it's a bigger molecule, it stays in our bloodstream, it doesn't go to our tissue, and because it increases the osmolarity of the blood, it attracts the water from surrounding tissue inside of the bloodstream, so it reduces the pressure.
And then he's also wondering if EVD has a role in these types of injuries if you don't have CTA.
Yes, because you don't put the ventricular drain anywhere close to that tumor. You put the ventricular drain inside of the ventricle to get the fluid out of the ventricle, reducing the volume, so reducing the pressure, so the blood can perfuse to the brain, practically managing the intracerebral or intracranial pressure. So,
Dr. Abbasi, at what point would you think about taking away the drain and putting in a shunt? How does that decision come about?
that is a decision that comes far, far later.
Okay,
We are still trying to save this young boy's life.
gotcha. Okay.
Okay, so we have done the surgery. You see the hole here where the tumor was, and it was a tumor. It was a medulloblastoma. Unfortunately, it was a grade 3 medulloblastoma, meaning it's an anaplastic configuration under the microscope.
Yeah.
We come back to that. So generally, medulloblastoma have better prognosis like glioblastoma. So this is the next picture in the MRI. Again, you see that where it was the tumor, it's only some gel foam. When we remove the tumor, on the surface of the brain, we put a very specific material that with thrombin, it stopped the bleeding, oozing, and this is you see very clean resection of the tumor. Now, this patient almost died, but after the surgery, I put the patient in an artificial coma so brain can relax and recover, and we put a CSF drain, the external ventricular drain, and patient was localizing to the pain, meaning that already jumped 2 points in the GCS. That is a very good sign. Over the next few days actually, we could wean the patient, and this patient actually was opening the eyes after 3-4 days and was responding and was extubated 5 days later. Now, this is the MRI. The tumor is completely removed, and that is a good thing. That the parents were ecstatic. This patient almost died, and we saved this patient's life. And since then, every Christmas they sent me a letter actually, but unfortunately this is not where it ends. Here again you see that where the tumor is just CSF, the tumor is gone, and we could literally see that there is really not much of the tumor is there anymore, because that is important. If the goal of the first surgery is just to save the life, not to resect the tumor. But I got a post-operative MRI with contrast. If any tumor was left, we would go in a second sitting and remove it, but there was none. Okay? Unfortunately, we know from this tumor, this is not all. This is the boy, and the parent actually, extremely happy. But one of the characteristics of these tumors is that they have small little cells that you don't see, but they are in other places that you cannot get out. To get all the tumor out, you have to resect way too much brain, and it would cause damage, more bad than good. So this patient, actually, we sent him then to Mayo Clinic, and they did what we call a chemotherapy. The part of treating this is chemotherapy, and that's why you see that he has no hair, because he went to Mayo, and he regained all the function. But part of this tumor is that you have to continue with the chemotherapy per protocol to reduce the risk of the tumor to come back. Now, parents started actually a non-for-profit in Sioux Falls, and they donated money for children tumor and so on. And unfortunately, the amount of the chemotherapy and radiation this patient needed to really, what's the standard, caused a secondary tumor. And about 9 years later, unfortunately, this patient succumbed to the secondary tumor and unfortunately passed away. I couldn't, obviously, I could save in that moment his life, but unfortunately, 9 years later or 8 years later, he still had a secondary tumor and died. Now, this is all I have regarding the picture for this, and I'm happy to answer any question anybody may have. So, but if you have any question, anybody, let's talk about it. We talked about the coma, exam for the coma. We talked about the brain and CSF anatomy and initial management of that. And we talked about one of the most common tumors in the childhood, which is medulloblastoma. Now, is there anybody asking any question, Amanda? Otherwise,
not currently, no.
Okay. So,
But I have some questions.
Yeah.
What are some things, if this is the most popular or most common tumor, what are some things to look out for?
Now,
or are there any signs?
Unfortunately, many of these tumors present when something happens, like the backflow of the fluid in the brain become obstructed, or it bleeds into the tumor. All of that is our emergency. Like this child was okay until he was not. And but sometimes as well there are some, because they are in the cerebellum. Dr. Coach, what is the function of cerebellum and what are the cerebellar functions?
So cerebellum is involved in a big way in stuff like dexterity and balance. So especially the middle part, the vermis, really has to do with truncal stability. So if you have a lesion there, you might not be able to stay straight to walk normally. It can also have to do with your ability to move smoothly. You might not be able to sense distance very well, so that if you want to try to reach out and grab something, you might miss it. It pretty much is a movement oriented. It's like a target almost. It's like and it enables you to target things and go after them, in a sense, from a movement perspective.
Yeah. So practically, the symptom you would be expecting from something like that would be what we call cerebellar function, which is gait, stability, and and walking practically. But unfortunately, many times this presents as a emergency with no other symptoms. Okay, I think this should conclude our case presentation today. If anybody has
There
a
is
question,
actually one more question.
okay.
But you did answer this. It's the chemo that caused the secondary tumor.
Radiation and chemo. The standard of treatment for this kind of tumors is not only surgery, but as well radiation and chemotherapy. Now, in this case, unfortunately, the tumor that came back was not the primary tumor, not the tumor that I removed. That means the radiation and chemo were successful, but we all know radiation and chemo, especially radiation therapy, can alter the nature of the tumor. Now, you may say, but then we shouldn't be doing radiation, but then we know the tumor definitely will come back. Whereas if we do radiation and chemotherapy, only in a small number of people, which unfortunately this young boy was in that group, the tumor came back. It is, there are certain tumors in the brain, like for example, we call that glioblastoma. It doesn't matter what you do, practically 100% these tumors are deadly. Medulloblastomas are not necessarily 100% deadly, but they have a bad prognosis, especially if you don't do radiation and chemotherapy afterward. And radiation and again, you know, combination radiation to operation, radiation therapy and chemo worked, but unfortunately, no procedure that we do has 100% results, and this was the situation with this young boy. Any other question?
How did he do from the time after you removed the initial tumor until the tumor came back? I mean, in terms of his rehab, and did he regain full cognitive function, and how was he doing?
Actually, the reason I'm browsing here is I have a video of this young boy that the parents sent to me that he's doing river dance.
Oh.
So he regained full function.
Full function, that's great.
Unfortunately, later on when he was getting treatment for the other tumor, he has to be on high dose steroid, and this was truly a tragic situation. But right after my surgery, within 4 days, the patient was extubated, and we talked about the management of CSF. I didn't need to put a shunt in, because what we do, there is a way we wean the patient of the external ventricular drain. We measure the pressure while we are clamping it, so we could restore the usual flow of the CSF. So I didn't even have to put a shunt in. And then within a month or so, now most of the function were fine. And I'm actually, it is on my Facebook, where the family sent me a video of him doing river dance. It is somewhere in my Facebook, but this is.
I think if you go to your photos, you should be able to find it.
Really?
Stop, go down. If you go down.
No, here photos or videos maybe.